Welcome to the webinar, Cardiopulmonary Management of the Organ Donor, the Respiratory Therapist Role. In 2019, there were 2,714 lung transplants performed in the U.S. Respiratory therapists play an important role in maximizing that number. The goal of this webinar is to educate bedside RTs on organ donation procurement and illustrate how they can help save lives by preserving donor lungs for transplant. This presentation was created by Jason Turner, Donation Clinical Specialist from LifeGift, and Jocelyn Phillips, a clinical trainer from Southwest Transplant Alliance. Right now, there are 114,000 people waiting for a life-saving transplant. More than 10,000 of them are right here in Texas. Of those 10,000, 143 are waiting for a lung transplant. The waiting list is always fluctuating, and a new patient is added to the list every 10 minutes. Not all patients on the wait list will be fortunate enough to receive an organ in time. 22 people die every day waiting for their gift. If you were to get all of the patients waiting for an organ transplant together, they would not be able to even fit inside the Dallas Cowboys Stadium. Organ procurement organizations, or OPOs, are responsible for finding organs for transplant. There are 58 OPOs in the United States. Texas is divided three ways. 3 OPOs serve the state of Texas. LifeGift is based out of Houston, Southwest Transplant Alliance out of Dallas, and the Texas Organ Sharing Alliance out of San Antonio. Each of the 58 OPOs are represented by a different color on this map. Notice how one OPO serves all of North Dakota, South Dakota, and Minnesota, while Florida, which is significantly smaller, has 4 OPOs. The regions were divided by CMS. In 1998, the Centers for Medicare and Medicaid Services, or CMS, decided that in order for hospitals to receive CMS reimbursement, they must create and implement written protocols for organ procurement. CMS specified that the participating hospitals must incorporate an agreement with an OPO and at least one tissue bank. They must maintain the opportunity for donation. Hospitals must notify their designated OPO of all deaths and imminent deaths in a timely manner. And the family of each potential donor should be informed of the opportunity to donate. Timely notification is within 1 hour of a vented neurocritical patient meeting one or more of the following triggers: a Glasgow Coma Scale, or GCS, of less than or equal to 5. The patient missing 2 or more brainstem reflexes. A DNR has been written, or a discussion of terminal withdrawal has been initiated. Patients who have been extubated are not candidates for organ donation, although they may possibly have an opportunity to be a tissue donor. Most of the human body has the potential to be donated. Eyes can be transplanted to restore vision. Lungs bring breath back to an end-stage pulmonary patient. Whole hearts and heart valves can be donated. A patient with cirrhosis or hepatitis can receive a new liver. The pancreas can be replaced in insulin-dependent diabetics. Bones can be used for facial reconstruction, limb salvage, and birth defects. Donated veins can restore blood flow to ischemic areas. Kidneys can free end-stage renal patients from the need for dialysis. Small intestines can help malnutrition patients absorb nutrients. Fascia, connective tissue, can repair soft tissue injuries. Skin can serve as a temporary dressing for burn victims, and cartilage can be used in reconstructive surgery. Working in the organ procurement world can be challenging. I worked as an organ donation coordinator for almost a year. It was very difficult emotionally. It's hard to compartmentalize as a coordinator. You are there on site at the hospital, managing the donor's care and supporting the family. OPO staff members are incredibly special people. Ultimately, I couldn't handle it emotionally. My husband and I have 2 boys, 13 and 2. One week I had 3 donor cases. A 36-year-old man who committed suicide and eerily looked an awful lot like my husband. A 14-year-old boy who overdosed, and a 2-year-old who was abused to death by his mom's boyfriend over a potty training incident. I knew after that week that I could not disassociate myself from these donors and their families to keep a clear head. I admire the organ donation coordinators that can maintain a healthy balance. They all have a connect to purpose. This is donation clinical specialist Jason Turner's connect to purpose. Ian was a 17-year-old who was pronounced brain dead after a car accident. Jason was Ian's organ donation coordinator and went to OR with Ian, where his heart, lungs, liver, kidneys, and pancreas were successfully recovered. Ian's gifts saved 5 lives. The 2 pictures in the bottom right are of a man who was in a farming accident and lost his right hand. Ian's mom got to hold Ian's hand after it was donated to this gentleman. There are 3 pathways to donation: donation after brain death, donation after circulatory death, and tissue donation. The responsibility of determining suitability is not ever the hospital's. The organ procurement organization staff will evaluate potential candidates for donation. Donation after circulatory death is an option provided to the family only after the family has made the decision to terminally withdraw life support. Circulatory death donors remain under the care of the hospital even after consent for donation has been received. The OPO staff works in conjunction with the hospital to ensure appropriate testing and/or therapies are completed prior to going to the operating room. The patient is extubated in the OR by the hospital respiratory therapist. Every hospital has its own DCD policy. If the patient does not expire after 60 or 90 minutes, depending on the hospital's policy, the opportunity for organ donation is lost, and the patient will be returned to their hospital room on comfort care. If the patient does expire within 60 or 90 minutes, organs that can potentially be recovered include lungs, liver, kidneys, and pancreas. In the future, it is expected that hearts will start to be an option for donation after circulatory death. This is already happening in Europe. Donation after circulatory death can be especially difficult for OPO and hospital staff. Oftentimes, the family of the patient chooses to accompany the staff to the OR and be with the patient for extubation. I remember extubating an 18-year-old in OR, and his mom was on one side of me and his stepmom was on the other side. If you've ever experienced a situation of imminent death of a child and heard that bone-chilling wail that a mom lets out when she realizes these are the last moments she will spend with her child, You know how tough this is. Brain death is legal death. It occurs when there is a neurological injury and the brain swells and herniates through the foramen magnum. After a patient is deemed brain dead, he or she can still be maintained on the ventilator and can still have cardiac activity with a pulse. But there is no brain activity. Brainstem reflexes are no longer present. The patient will no longer be able to move or react. Spinal reflexes may still be present. Brain death is often incomprehensible for the patient's family. They see the patient's heartbeat on the monitor, the patient is warm to the touch, and they see the chest rising and falling when the patient is on ventilatory support. Brain death is the irreversible cessation of all functions of the brain, including the brainstem. Texas state law recognizes the diagnosis of brain death as legal determination of death. Every hospital has a policy on the process of brain death determination. Best practices in pronouncing brain death include following state legislative requirements and the American Academy of Neurology's practice parameters, as well as ensuring practices following hospital policy. In clinical practice, EEG, cerebral angiography, nuclear scan, transcranial Doppler, CTA, MRI, and MRA are currently considered to be ancillary tests. Ancillary tests can be used when uncertainty exists about the reliability of parts of the neurologic exam or when an apnea test cannot be performed. Cerebral blood flow is a good option as an ancillary test when the patient's family is having a hard time accepting the death, because it offers a visual picture to show the lack of blood flow to the brain. Apnea testing is not an ancillary test. It is considered the gold standard and is an essential part of the clinical evaluation. The process to determine brain death may vary slightly from hospital to hospital. Every hospital's policy should at least require these basic components. The hospital physician must establish irreversible and proximate cause of the patient's coma and exclude the presence of drugs that may cause central nervous system depression. The hospital staff should ensure that no neuromuscular blocking agents are in the patient's system. Any lab imbalances should be corrected as much as possible. There is a saying in healthcare that a patient is not dead until they are warm and dead. The American Academy of Neurology's require a core temp higher than 36 degrees, which would be 96.8 degrees Fahrenheit. The patient's blood pressure should be stabilized with a systolic of at least 100. For pediatric patients, most hospitals will perform 2 separate clinical exams, either 12 or 24 hours apart. I mentioned brainstem reflexes earlier. So what are they? A brain-dead patient's pupils will not react to light. They will display doll's eyes, meaning when the physician moves the patient's head from side to side, the eyes stay fixed, similar to that of a doll's. If you or I had ice-cold water squirted in our ear, it would be painful and we would have a reaction. Brain-dead patients do not react to the cold caloric test. The physician will touch the patient's eyeball and the brain-dead patient will not blink. When the physician suctions the patient and sticks the Yankauer in the back of the patient's throat, there will be no cough or gag. Lastly, there will be absence of facial muscle movement to noxious stimuli. The physician will apply deep pressure to the patient's face, and the brain-dead patient will not move or grimace. Prior to performing the apnea test, it is important to ensure your patient is stable enough to tolerate it. After all, the goal is to maintain the opportunity for organ donation, not to induce cardiac arrest. Check your patient's vital signs. Is the blood pressure at least 100? Is their heart rhythm regular? Once an order for the apnea test has been written by the physician and you have decided the patient is stable enough to withstand the apnea test, pre-oxygenate the patient with 100% FiO2 for a minimum of 10 minutes. Expose the patient's chest and lie the patient flat so that you can visualize any respirations. Reduce the PEEP to 5 and obtain a baseline blood gas. Check the results to make sure the patient is not a chronic CO2 retainer. Ensure that the patient's pulse oximeter has a good waveform and disconnect the ventilator circuit from the endotracheal tube. Place oxygen tubing down the ET tube close to the level of the carina and deliver 100% FiO2 at 8 liters per minute. Make sure that the oxygen tubing is not occluding the ET tube. You can cut the end off of the tubing so that the thick connector does not take up too much space in the ET tube. Or you can use a pediatric nasal cannula that you cut so that you're just using the tubing part. Important things to remember while performing the apnea test. Watch the patient's chest and abdomen for respiratory movements. If no respiratory movements are observed, repeat an ABG after 8 minutes. Ideally, your patient will have an art line so that you will be sure that blood will be obtained quickly. If possible, use a point of care machine to run the blood gas so that you can stay at the patient's bedside. Abort the apnea test and place the patient back on the ventilator if respiratory movements or efforts are present, if the systolic blood pressure drops below 90, or if the patient's pulse ox decreases to less than 85% for more than 30 seconds. The apnea test is positive if there are no respiratory movements and the PCO2 result is more than or equal to 60, or if it increases at least 20 from baseline. Apnea tests should not be performed on COPD patients. For example, if the baseline blood gas reveals a PCO2 of 65 with a normal pH, notify the physician that the test cannot be performed. It is important to document the reason why an apnea test was not able to be performed.
The bedside RT can help to increase the number of lungs that are able to go for transplant. Pneumonia and atelectasis are common in organ donor patients. Neurologically injured patients are always at high risk for aspiration. And especially with brain-dead patients, atelectasis occurs since the patient is unable to deep breathe or cough. The OPO coordinator may request things from the hospital staff that may seem strange. The RT may be asked to turn down the ventilator flow to 20 or 30 to reach an I to E ratio of 1:1 in volume control. Of course, we would never do this to our living patients. It's uncomfortable to breathe with the flow that low. But remember, brain-dead donors are dead, and this odd recruitment technique will not bother them. During lung allocation, I once had a transplant center request 600 milligrams of Mucomist given down the OG. Now, I have heard of giving Mucomist orally for Tylenol overdoses, but this seemed like a very weird request. But once the lungs are placed, we're basically at the mercy of the transplant centers. Those lungs are essentially theirs. So most times, the OPO coordinator will just do what the transplant center requests. There are many physiological factors that pose challenges to lung donation procurement. After the process of brain herniation, a catecholamine storm sets in. The lungs are highly susceptible to injury resulting from the rapid changes that occur during the catecholamine storm. At the moment of peak vasoconstriction, left-sided heart pressure exceeds pulmonary pressure, temporarily halting pulmonary blood flow. Exposed lung tissue is severely injured, resulting in interstitial edema and alveolar hemorrhage, a state commonly referred to as neurogenic pulmonary edema. Hypoxia in the absence of pulmonary edema is often seen in the brain-dead patient, and a variety of factors are involved, including ventilation-perfusion mismatch, microatelectasis, and increased oxygen consumption, pneumonia aspiration, pneumothorax, pulmonary contusion, or other residual effects of the morbid event that caused brain death can also lead to hypoxia. In brain death, a marked increase in circulating catecholamines occurs within 2 to 5 minutes and returns to normal levels within 15 minutes. Epinephrine, norepinephrine, and dopamine all increase drastically, which creates major hemodynamic instability. The lungs normally contain approximately 20% of the body's total blood volume. Pulmonary capillary wedge pressure shoots up to more than 50, which leads to leaky vessels and ultimately causes pulmonary edema. Studies performed on animals show that this happens in approximately 1/3 of brain deaths. This picture illustrates pulmonary edema on a chest X-ray. The lungs have a bilateral, fluffy appearance. The biggest challenge I experienced with donor management was definitely fluid balance. It is important to keep the lungs dry, but at the same time, you need the donor to be hydrated to keep the kidneys perfusing. Thankfully, the kidneys are the most resilient and forgiving organ of the body. And the liver is usually good, or it isn't. So the lungs and heart were always my main priority during donor management. Ventilation perfusion mismatch, also referred to as VQ mismatch in shunt, is the main pathophysiological mechanism of hypoxemia, ensuing from airway closure and atelectasis due to lung surfactant depletion and/or increased extravascular fluid around the lungs, causing oxygen impairment. Organ donation coordinators are very focused on lung recruitment. The maneuvers they ask you to perform may sound a little unorthodox. It can also be a very tedious and time-consuming process. Donation coordinators have various clinical backgrounds. I've worked with RNs, RTs, paramedics, and even surgical techs. So they will usually lean on the bedside RT for suggestions. It is always okay to let the coordinator know if you have a heavy workload that shift. They should be flexible and show you understanding. For brain-dead donors, they can do a lot of the work themselves, since the donor is no longer technically under the hospital's care. Donor management is a good learning experience. If you are interested and why certain orders are being placed, don't be afraid to ask them. Most organ donation coordinators enjoy opportunities to teach and explain the method behind what can seem like madness. Probably the most common technique for recruitment is to gradually increase the PEEP by 2 every 2 or 3 minutes, all the way up to 20. Of course, be mindful of your plateau pressure and watch your art line pressure to make sure your donor does not become hypotensive. If the donor tolerates it, stay at 20 for a few minutes and then slowly come back down. Lung conditioning is typically a little more immediate. Take your current mean airway pressure and add 5 to it. Increase your PEEP to that number for approximately 10 minutes, and then reduce back down by 2 every couple minutes until you return to the original PEEP setting. In brain-dead donors, you can play with inspiratory and expiratory times and ratios in ways that seem illogical for living patients. 1-to-1 was always my target ratio when I was managing lungs for donation. I personally liked using pressure control because I could set my inspiratory time to achieve that 1-to-1 ratio. That being said, transplant centers seem to only like volume assist control. So before I would start lung allocation, I was always switched over to volume control mode. John Peter Smith Hospital in Fort Worth has a lot of success using bilevel for lung recruitment. Bilevel is great, but again, transplant centers will want you to be on volume control. It's usually an easier transition with less de-recruitment, transitioning out of pressure control to volume control than it is with a bilevel mode. Donors often must be transported off the unit for various tests. They may go for a liver biopsy, a heart cath, CAT scans, maybe nuclear med. It is so very important to clamp the ET tube anytime you break the ventilator circuit. If you don't clamp the tube, you'll lose all the work you did to get rid of all that atelectasis. What do you need to clamp the tube? Ask your organ donation coordinator if you don't have hemostats. It is also recommended to use a transport ventilator for any traveling you do with lung donors. The picture on the left was taken at the beginning of a 12-hour shift. The picture on the right illustrates the same set of lungs at the end of that shift. The bedside RT performed excellent respiratory therapy on these lungs and completely cleared the atelectasis. The lungs on the right are a result of effective CPT, successful recruitment maneuvers, and dedication to repositioning every 2 hours. This donor actually traveled to radiology for a CAT scan during the shift. The tube was clamped when the circuit was broken, and he was transported with the new Parapack ventilator. Pneumonia. Pneumonia does not necessarily eliminate the chance of lungs going for transplant. With the appropriate treatment, oftentimes pneumonia can be resolved prior to lung allocation. Lung transplantation's biggest enemy is time. It's not really a matter of whether or not the pneumonia can be resolved. The question that is usually asked is, can we get rid of the pneumonia before we go to the operating room? With the introduction of ex vivo lung perfusion technology, we now have time back on our side. Ex vivo lung perfusion is an innovative therapy applied to donor lungs outside of the body before transplantation that improves organ quality and makes lungs that were previously unsuitable safe for transplant. As respiratory therapists, we know that lung size is dependent upon height. Of course, we wouldn't be able to fit the adult lungs on the left into the infant on the right. Transplant centers always request lung measurements from a chest X-ray. While the measurements provide a general idea of lung size, there are times that we'll get to the OR, open the donor up, and on visual inspection, the recovering surgeon decides that the lungs will not fit properly in the recipient. Does that mean the lungs will just go to waste? Not always. Transplantation is always the goal. When this happens, the organ donation coordinator will have to reallocate from the operating room. It's always a good idea to have at least 2 strong backup recipients, where transplant surgeons have agreed to back up the lungs from the OR before starting the recovery process. Now, of course, I understand we are focusing on lungs, but the picture on the far right is the heart that was recovered from this infant on the slide. I just had to include it. It was the smallest heart I had seen go to transplant during my time as an organ donation coordinator.
Prior to offering lungs to transplant centers, there are several goals OPOs try to meet. When you draw a challenge gas on 100% FiO2 and a PEEP of 5, you want the PaO2 to be at least 350. Perform a pre-allocation chest X-ray. It should be clear, without infiltrates, atelectasis, effusions, or pulmonary edema. Continue to reposition the donor at least every 2 hours and make sure the ET tube is 2 to 5 centimeters above the carina. Hopefully, secretions are minimal and clear or white. Fluid balance is challenging in donor management. Sometimes you feel like you are chasing your tail, but keep chasing it nonetheless. It is a constant balancing act. When possible, it is recommended to use active humidity on donors rather than an HME. For brain-dead donors, a therapeutic bronchoscopy should be performed at least every 24 hours, and in some cases, every 12 hours. Remember to clamp the ET tube when you break the circuit for the bronchs. Ideally, the lung donors are less than 55 years old. If they have a smoking history, it should be less than a 20-pack year history. COPD and asthma are not automatic rule-outs. Donors are evaluated on a case-to-case basis. Donors with a history of any cardiopulmonary surgery are less likely to have lungs go for transplant. The therapeutic bronchoscopies provide a good visual picture of the lungs. I remember one case I was on. It was a 30-year-old female. She and her husband converted an old school bus into a tiny home. When we bronched her, we saw a stringy metallic-looking substance that covered her airways. When the culture came back, it ended up being mold. Unfortunately, we wouldn't have enough time to kill the fungus, so we were forced to shut down the case. These 2 pictures represent your best case scenario. These are beautiful lungs that went for transplant. Notice the bright pink color while the lungs are still being perfused. The picture on the right is after the lungs have been flushed out. Lungs are transported, inflated, to the recipient's hospital. You see that dark spot on these lungs? That is a pulmonary infarction due to a pulmonary embolism. These lungs actually still went for transplant. After the lungs were removed, the recovering surgeon performed a lobectomy on the back table to remove the infarcted area. Teamwork is essential. Bedside hospital staff can help more organs go for transplant. Brain death causes significant changes in the lung function of a potential donor. Clinical assessment, ventilator strategies, combined with aggressive pulmonary care allow us to provide more lungs for transplant. We serve as the bridge between those who make the decision to donate and those who need a life-saving transplant. We accomplish this mission when all are selfless team players. Tell someone about organ donation and the importance of donor registration by supporting the Donate Life Texas Registry. You can learn more about donation success stories on the Donate Life website. For example, the gentleman in the top right corner is Viva la Vida. Despite Viva's positive HIV status, he received the gift of a new liver in 2016, thanks to the HOPE Act that went into effect November of 2015 that allows HIV patients to receive organ donation. HIV patients may also become donors and donate to other HIV-positive patients. In order to receive your 2 CRCEs, simply email the answers to these questions to heroesofhealthcare@gmail.com. Name 3 pathways to donation. Who is responsible for managing the care of donation after circulatory death or DCD donors? The hospital or the OPO? What type of storm takes place during the brain death progression process? In the state of Texas, families can override first-person authorization of a registered donor. True or false? Asthma is an automatic rule-out for lung donation. Is that true or false? Thank you so much for participating in this webinar. I hope you enjoyed the content. We are always trying to improve and welcome any constructive criticism and/or suggestions you may have. Let us know what other topics you would be interested in, and tell your RT friends about Heroes of Healthcare educational events. I look forward to reading your answers to the quiz, and we'll send your CRCE certificate electronically to you.